Thank you. Good afternoon, everyone. You can see this photograph on the screen, which has been taken from one of the experiments. And in this study, this razor blade, which you can see in this photograph, was placed in a fluid, which got corroded in this fluid, and we can see very clearly here. After 15 hours, there is some considerable erosion has happened, and there is very significant corrosion has happened of this blade after 24 hours. And it would not be surprising to know that the fluid used in this experiment was our stomach acid. Paul and colleagues, they have published this study in Gastrointestinal Endoscopy Journal, which has reported that our stomach acid is strong enough to dissolve very hard objects, even metallic objects like a razor blade. That is how stomach acid forms a first line defense mechanism of our body by killing the microbes and germs that are present in the food that we eat. But when this acid is produced in excess amount, commonly known as acidity, that leads to the beginning of commonly seen gastric issues and gastric disorders. This panel discussion is going to cover this very topic of gastric acidity, focusing on the role of antacids in the management of acidity. I, Dr. Rahul Mandlik, welcome you all on behalf of Shalina Healthcare to this panel discussion. The panel today which we have is very interesting blend of experts coming from basic pharmacy research as well as clinical practice. A brief overview of Shalina Healthcare. Today, we are one of the largest pharmaceutical companies in Sub-Saharan Africa. And from last 35 years, we have made it our mission of manufacturing quality medicinal products and to make them available across Sub-Saharan Africa at affordable prices. And we achieve this by manufacturing these products at our own WHO approved facility. And we are also involved in several social activities. Today's panel discussion is part of our initiative, SPEED, which stands for Shalina Professional Engagement and Education. Under this initiative, we have rolled out a full bandwidth of online as well as offline educational activities for healthcare professionals. With this, let me welcome our eminent panel members, starting with Dr. Bright. Dr. Bright is a consultant physician and gastrointestinal endoscopy fellow, and is the head of clinical care at LMUTH in Lusaka in Zambia. He is also head of Department of Internal Medicine and senior lecturer in LMU in Zambia. He is vice president of Zambia College of Physicians, and his expertise are mainly in gastrointestinal area, that is gastrointestinal, esophageal, liver, biliary tract diseases, as well as IBD. He has published many articles in international medical journals, and he has played a very crucial role in hepatitis B UTH cohort study conducted in Zambia. Welcome, Dr. Bright. Professor Bola is associated with Department of Clinical Pharmacy at Faculty of Pharmacy in OAU, Ile-Ife, Nigeria, and he is also former vice dean of this institution. Currently is a member of Education and Research Subcommittee of Pharmaceutical Society of Nigeria, and he is co-editor-in-chief of African Journal of Traditional, Complementary and Alternative Medicine. He is also a co-editor-in-chief of African Journal of Infectious Diseases and a technical director of African Traditional Herbal and Medical Supporters Initiative. He has been supervising and helping many students passing out with their MSCs as well as PhD, and he has published more than 50 articles in national and international journals, and he is a reviewer of many international journals. Welcome, Professor Bola. And Professor Ayansu, who belongs to head of Professor Ayansu is the head of Department of Herbal Medicine at Faculty of Pharmacy and Pharmaceutical Sciences at KNUST, Ghana. He is the chairman of Academic Social and Research Pharmacist at Association of Pharmaceutical Society of Ghana, and he is a Commonwealth Fellow and a recipient of Seeding Labs Instrumental Access Award. He actively maintains his research interest, and he has published many articles again in reputed international and national journals, and he has presented many research works at national as well as international platforms. He is a reviewer for several peer-reviewed international journals. So welcome to all panel members. And
Thank you.
dear audience, during this panel discussion, particularly this program is divided into three parts. Part one, where all the panelists will present their slides. In part two, we will go into very interesting and engaging panel discussion, and part three, where we will take up some of the questions asked by you. So stay tuned. With this, I welcome now our first panel member, Dr. Bright. Over to you, sir.
Thank you very much, Dr. Rao, and I wish to welcome everyone to this panel discussion. And I've already been introduced. I'm Dr. Bright Nsokolo from Zambia. I will take you through the pathophysiology, clinical presentation, and how we make a diagnosis of hyperacidity. Please, I have the slides.
Can you see the slides, Dr. Bright?
Yes, please. Thank you
Yeah.
very much. So, just to define gastric hyperacidity, this is also called acid dyspepsia and is characterized by excessive production of gastric acid by the stomach. So, we do have high levels of gastric acid, which in turn can cause reflux. And together with that, you may have gastric ulcers, gastritis, indigestion, nausea, and flatulence. And we also have gastric reflux, which is defined as reflux of gastric contents with a pH of less than 4. How about GERD? This is a condition that develops when the reflux of stomach contents causes troublesome symptoms and or complications. So GERD is also classified based on the appearance of esophageal mucosa when we do endoscopy, and it can be either erosive esophagitis or non-erosive reflux disease. So for erosive, we do see changes when we do endoscopy, and for non-erosive reflux disease, there are no changes when you do endoscopy, but the patient has signs and symptoms of GERD. Slide, please. Thank you. So I think for us to understand how hyperacidity takes place, it's important that we understand what happens in the stomach. How is acidity maintained? So we have different types of cells in the stomach that are responsible for maintaining the acidic environment in the stomach. We have the gastrin. We have the G cells, which produce gastrin. We also have the enterochromaffin cells that produce histamine. We have acetylcholine as well, which is produced at the nerve endings of the vagus nerve. And of course, we have the D cells that produce somatostatin. So for gastrin, when it is produced, I wish to take you to the picture here. Gastrin is produced in response to gastrin-releasing peptide. And when it's released, it stimulates the enterochromaffin cells to produce histamine, and histamine in turn stimulates the parietal cells to secrete the acid. However, directly, you can have effect on the chief cells, which also produce pepsinogen, which is converted to pepsin. On the parietal cells, you may also get stimulation via the nerve endings, which muscarinic in nature, and you have the acetylcholine there, which also plays that role. And you realize that most of the drugs that we're going to talk about, it's either they are neutralizing the acid which is already produced, or they are inhibiting secretion of the acid from the parietal cells by inhibiting the hydrogen potassium pump, the hydrogen potassium pump which secretes the hydrogen. These other drugs may also inhibit histamine action on the parietal cells, the receptors for histamine on the parietal cells. So this is what happens in the stomach. And hyperacidity can occur as a result of gastrinemia because there is too much gastrin being produced, leading to stimulation of the parietal cells. But remember that we also have the D cells here, which produce somatostatin. Somatostatin has an inhibitory effect on the G cells which produce gastrin. So if you have any substance or chemical that inhibits production of somatostatin from the D cells, you are going to have gastrinemia. You're going to have hyperacidity because gastrin will be produced without the inhibitory effect of somatostatin. Next slide, please. So when you're talking about hyperacidity, it's important that we mention H. pylori infection. So H. pylori infection is very important and it contributes to hyperacidity. In some individuals, it is actually associated with increased basal and stimulated gastric acid secretion. We have the prostaglandins as well, especially prostaglandin E2, which protects the mucosa lining, the mucosa that lines the stomach. Okay, then we do have the NSAIDs, non-steroidal anti-inflammatory drugs, which non-selectively block COX-1 and COX-2, leading to reduced production of prostaglandins. And we know that prostaglandins, they protect the mucosa of the stomach. So how about GAD? So GAD reflects an imbalance between injurious or symptom eliciting factors and defensive factors in the esophagus. So which ones are these symptom eliciting factors? We have reflux contents, or reflux events. So by reflux events, we are referring to the frequency of opening of the lower esophageal sphincter. We know that a bit of reflux is actually physiological, but if the frequency is increased, you find that you're going to have increased reflux events, and this may promote gastroesophageal reflux disease. Then we have acidity of the contents. If the contents are very acidic, you also predispose the esophagus to damage. If the esophagus is also hypersensitive to gastric contents, it would also elicit symptoms. Defensive factors involve the esophageal acid clearance, the clearance here of the acid. If there is dysmotility, for example, in those with autoimmune disease with dysmotility, you find that you have the acid accumulating here instead of being cleared. And also the integrity of the mucosa of the esophagus. The reflux barrier at the gastroesophageal junction is anatomically and physiologically complex. And of course, it is vulnerable to several potential mechanisms of reflux. We have several mechanisms of reflux, which include the transient opening of the esophageal sphincter, okay, hypotensive lower esophageal sphincter, all these mechanisms that may cause reflux, and of course anatomical damages, anatomical changes that occur at the lower esophageal sphincter, such as when somebody has got hiatus hernia. Next slide, please. So what are the clinical features of reflux? So the majority of patients with peptic ulcer disease, they seek attention because of epigastric pain. Most of them would present with epigastric pain. However, there is a significant fraction of these patients who may present with complications of peptic ulcer disease, such as iron deficiency anemia as a result of prolonged blood loss, hemorrhage, and of course, sometimes patients present for the very first time with perforation, and this becomes an emergency, a surgical emergency. So in this setting, pain tends to occur 1 to 3 hours after meals during the day, and it's actually worse at night between 11 p.m. and 2 a.m. and is relieved by taking alkali or food. Nausea, vomiting, bloating, belching are some of the additional complaints that the patient may have. So we can also have penetrating ulcers. So these ulcers have pain which is occasionally referred to the back and left upper quadrant, and of course the chest. And this sometimes is misinterpreted as a patient having a cardiac problem, patient having acute coronary syndrome. So classic symptoms of GERD are heartburn and regurgitation, but when you have complications, you may actually have dysphagia, chest pain, and pain on swallowing. Esophageal symptoms may also include cough as a result of continued reflux. That's why sometimes we get a lot of patients being referred from the ENT specialist to our clinic to tackle the reflux. They may have hoarseness of voice, wheezing, and of course nausea. And this side is just elaborating how bad ulcers can be. These are different locations for the ulcers, different sites. You also have the appearance of a deep ulcer here in the duodenum, and may also have a gastric ulcer here, which is in the antrum. This is a gastric ulcer there in the antrum. Next slide, please. So then how do we make a diagnosis of hyperacidity? Usually, I must say that for gastroesophageal reflux disease, symptoms tend to be typical, such that in most cases, you don't even need to do endoscopy to make a diagnosis. When somebody presents with typical clinical features of gastroesophageal reflux disease, we are able to make that diagnosis and start the patient on treatment. But endoscopy remains very important, especially if these patients do not respond to proton pump inhibitors, they don't respond to H. pylori eradication therapy. You may have to do endoscopy. We also check the acidity of the esophageal contents, and we also do what we call esophageal impedance pH testing, which is actually much better when you compare this to wireless pH capsule or the traditional pH probes in order to check the pH. This is important in that it has the advantage of detection of non-acid reflux. Remember, we just don't have acid reflux, we also have non-acid reflux, and when you do this investigation, it tends to give you that diagnosis. So performing esophageal manometry in patients is also important, especially in those with dysphagia and regurgitation, prior to invasive anti-reflux therapies, okay? And this includes those with esophageal motility, dysmotility, especially those that may have autoimmune disease. With those few remarks, I wish to invite Prof. Gola to give us the treatment options in gastric distress. Please, Prof. Prof, are you there? You are muted. You need to unmute yourself.
Thank you, Dr. Bright. My brother from Lusaka, Zambia. the whole of Africa stands with you as we lose one of the foremost African leaders. Can I have the next slide?
Thank you.
We are heading for a treatment option in gastric distress. As you can see, Dr. Bright has gone through, a whole gamut of possibilities, in clinical setting. And after diagnosis, the treatment options are just what comes, and that's what we're going to discuss briefly. Can I have the next slide? Yeah. Now, in gastric discomfort, we have to consider so many options. One of the options, are the antacids. When we're talking of the antacids, we have two clear classes: the systemic, exemplified by sodium bicarbonate, and the non-systemic ones. The non-systemic have a lot of components, a lot of examples, which can be summarized as weak bases of metals, and such metals are aluminum, magnesium, sodium, calcium, and these are, when combined, with the hydroxide salts, they make a good base that we can call antacids. Next, we have the H2 receptor blockers, which came immediately after the antacids. They were, until their arrival, particularly until the arrival of cimetidine, antacids, were the mainstay of therapy in all gastrointestinal discomforts. So as we go and list some of the examples, cimetidine, which was a forerunner, then we have ranitidine, we have famotidine, and nizatidine. Now, when we talk of all this, there are more, but before we talk about the other classes, let's look at, and when you hear the word antacids, like it has been previously pointed out, you have something that neutralizes an already secreted acid, or something that prevents the secretion of such acid. So in this context, when we're talking of gastric discomfort, it can either come from secreted acids, or that secretion can be inhibited, which makes it proactive. If I have the next slides, we will come to what I'm talking about. Now, the other two classes are the proton pump inhibitors, which actually prevent, largely, they inhibit the production or the secretion of the gastric acid through a not too complex method. But by the time we look at the different examples, starting with omeprazole, which was a forerunner, which was eventually modified to get lansoprazole, dexlansoprazole, rabeprazole, pantoprazole, and esomeprazole. All these work on the proton pump, which is a hydrogen pump. Once it's like an enzyme, and once this is inhibited, you have a reduction in the gastric content of the stomach. In other words, we are saying that there's no one approach. There may be, utilization of several approaches, and not common because of several side effects are the anticholinergics, exemplified by pirenzepine. Pirenzepine, expectedly, as a muscarinic receptor blocker, will cause a lot of effects, especially CNS side effects. So for this, these are the options ordinarily, that one may employ depending on what the doctor or the clinician diagnoses. Uh, from ordinary acidity to ulceration, some of these can be deployed or employed, to solve some of these problems. Um, Next slide. Yes, I'm handing over to Professor Isaac Ayensu from Ghana.
Thank you very much, Professor Bola and Dr. Bright. And I'm very grateful for all the excellent introduction to acidity, gastric acidity. And I'm happy with the topic, revisiting antacids for gastric acidity, connecting basic research to clinical outcomes. Next slide, please. I want us to go back to the basics so that we can understand the options as already described by Professor Bola. If you take an antacid, we are talking about a product that is an antidote for reducing the hydrogen ion in the stomach through the process that we call neutralization reaction. What we mean by neutralization is that already if you have a very high content of acid, the only way you can bring the acid content down is by reacting it with a base. So an antacid has capacity to react with the secreted acid in the stomach so that the acid capacity to corrode is eventually reduced. So antacids would say are basically basic in nature. When we say something is basic, then we are looking at the pH, which starts from 1 to 14. At pH of 7, there's what we call neutrality. Beyond the pH of 7, we go into the basic region. So for the acidity, it is starting from 1 to maybe 6.9, but from 7, there is neutrality, and after 7, we have alkalinity. And so antacids would always be able to keep the acidity of the stomach above the dangerous range of below 4. And they would exist basically as buffers. When we say a buffer has capacity to maintain the pH of a substance either by balancing it with more acid or balancing it with more base. The antacid's property is to ensure that it keeps the acidity or the alkalinity of the stomach above the pH of 7. The interesting thing is that if you are able to change the gastric pH from 1.3 to just 1.6, you are able to neutralize 50% of the gastric acid. And interestingly, to raise it 1 point, that is from 1.3 to 2.3, you are neutralizing close to 90% of gastric acid. Let me explain what we mean by pH here. Now, the pH is a logarithm number. What it means is that if you have a pH of 1 and it is increased, or for that matter, it is reduced from 1 to 2, you have actually caused 10 times dilution of the substance. If you would move from pH of 1 to 3, it becomes 100 times dilution. So if you have a gastric acidity of 1.3 and you are moving it to 2.3, in effect, you are diluting the gastric content by 10 times. So if you have any antacid and it has capacity to change the pH from the acidic range towards the basic range, then you are actually saying that the higher concentration of the gastric acid is going to be reduced. because you are causing a great dilution. When it is highly diluted, it means its effectiveness as an acid is drastically reduced. And that is how these antacids are able to work. Next slide, please. And so if we pick up an antacid, Dr. Bola gave us an initial understanding that some would work as systemic antacids and some would also work as non-systemic. Systemic because they are capable of being absorbed and getting into the blood in order to have their effect. On the other hand, we have the non-systemics. The non-systemics are non-absorbable, which means they can have a local effect. So as Dr. Bright rightly indicated, if we have this excess acid, it is sitting in the stomach region. So that if you have an antacid that is non-systemic, it would stay with the gastric juice and then reduce its capacity to corrode the stomach, bringing relief to the patient and to the one who is taking it. So several examples, including the aluminum-containing antacids, are available. The calcium-containing antacids are also there. The magnesiums are there. And then we also have the combination antacid preparations that would even combine substances like simethicone. We'll talk about that later. These have capacity to also defoam. There's something we call the rebound acidity. If you're not careful, you could give a product that would eventually also cause excess production of acid. But then if you have the combination antacid with simethicone present, you are able to foam or to take off these excess acids to bring more relief. Thank you, Dr. Raul, and I think we can continue from here.
Thank you so much to all panel members, Dr. Bright, for wonderfully summarizing the basics from clinical side about the disorder, and Professor Bola for letting us know different treatment options that are available today, and Professor Ayansu, thank you so much for teaching us from the basics like what is pH and what is the ideal pH range that is uh, taken by any antacid. Okay, so great. With this, I think we have set the ground for further discussion now, and with this basics, I'm sure, and our audience will now also understand some of the questions they are going to be, or some of the points they are going to be brainstormed here by these experts on the panel. So please allow me to go ahead and put forward some points for the discussion here. Can I proceed?
Sure.
Thank you. So, uh, Professor Bola has you have talked about different options, including antacids. Uh, we would like to know, Professor Bola, that which are the typical physiochemical, pharmacokinetic, or pharmacodynamic properties of the antacids they have.
Yeah, thank you very much. For anything to qualify as antacids, it shouldn't be absorbable. That means when you look at the chemical components, you see that they are mostly inorganic salts, of metals, that is hydroxides of some metals, aluminum, just like I've said. And when you look at them, they don't qualify for absorption. So when you talk of pharmacokinetics and you look at the conditions for absorption of molecules, you see that most times the antacids don't, they don't qualify for absorption. One, they are highly ionized, and it's, when there's ionization, absorption is not encouraged. They are also not lipid soluble. So most of the times, this plays a lot, making them unabsorbable, they are also high molecules, so that the molecular size also prevents them from absorption. So when we look at the pharmacokinetics, which are derived also from their physical chemical properties, being largely inorganic salts, that makes the issue of the of absorption and therefore the pharmacokinetics. Even the ones that are absorbed, like sodium bicarbonate, it is after conversion, is the sodium chloride product that's actually absorbed into the system. So, in terms of the physical chemical properties, in terms, also dwelling into pharmacokinetics, you know that most antacids, almost all of them, in fact, for anything to qualify as an antacid, it has to have some of these properties, making them unabsorbable to produce local effect, as we have been told. So
Right.
that answers that question.
Right, Prof. So, what can we say? Like, for example, sodium has single positive charge on it, and magnesium has more charges. Aluminum has even more charges on it. It is making it less absorbable than the sodium.
Yes, well, because we are not talking of sodium chloride, we are talking of hydroxides of sodium, or sodium bicarbonate or sodium carbonate. So some of these, again, look at my opening statement that they are inorganic salts.
Yeah.
That primarily prevents them. Most of our drugs are weak organic bases or weak organic acids. But when we have something that is as strong as sodium bicarbonate or all of those, they are not candidates for absorption. That's why you have most of the antacids largely as unabsorbable thing because of their large sizes, inorganic nature,
Yeah.
the components, bulk molecules, that react with acid. And when they react with acid, they come to form the original base that we put. And remember, something comes into play, the lipophilicity comes into play. They are not lipophilic, and therefore they are not candidates for absorption.
Got it, Prof. So, in nutshell, I think we have understood here that why aluminum, magnesium containing or calcium containing antacids, they are non-absorbable because of these all factors. I would like to go here to Dr. Bright and would like to know that what is relevance of these all properties, doctor, in clinical practice?
Well, thank you very much. Pharmacokinetics of these antacids is very important, and we know that when we're talking about pharmacokinetics, we are talking about how a drug is absorbed, distributed in the system, how it's metabolized, and how it gets excreted. So if a drug, for example, that has aluminum, that has magnesium, is easily absorbable, that means that this may accumulate in the system, especially say if somebody has got chronic kidney disease. That becomes very important because these are eliminated through the kidneys. And if the kidneys are not working well, you're going to create hypermagnesemia, you're going to have accumulation of aluminium in the system. And we know that aluminium can even be neurotoxic. So pharmacokinetics of these drugs have got clinical importance, and it helps us to make choices. If somebody comes to me, they've got hyperacidity and they've got CKD, I'll be very careful when I'm choosing these antacids. I'll look at the best option. And another example is, let's say somebody is hypertensive and they are taking an antacid which has lots of sodium and it can easily be absorbed. That would mean that the sodium would accumulate in the system and cause water retention and may worsen the hypertension. So pharmacokinetics has got important clinical effects. Thank you.
Right, perfect. And so Dr. Bright, you have talked about some of the special populations considering the nature of antacid, whether it is systemic or non-systemic. You already have mentioned about patients with CKD or having hypertension. How about the pregnant woman, doctor? Which type of
Oh,
antacids from these two classes will go well safely?
well, thank you very much. I've already talked about those with hypertension and those with CKD. And of course, for pregnant women, you don't want to give an antacid that's going to be absorbed and then get concentrated in the breast milk if they are lactating and so forth. So those antacids that are based on magnesium trisilicate or aluminium hydroxide are not so much recommended in patients who are pregnant. Those patients who are pregnant are better off being given other options, such as maybe sucralfate, which cannot be absorbed, and of course they act locally. And these, in as much as they are not antacids, of course, they are going to line the stomach mucosa and prevent damage and, of course, promote healing just in case they are ulcers.
Right, Doc. Uh, to Professor Ayansu, would you please enlist the parameters? They are very crucial, in determining the efficacy of any antacids in maybe in lab studies.
Thank you very much for that question. I would want to make some suggestions here that anytime someone is having hyperacidity, the consideration for an antacid becomes a critical decision. Why am I saying so? An antacid should have a certain capacity. That capacity would mean that it is able to actually neutralize a certain quantity of the acid. And that property, if you want to measure for an antacid, it's its efficacy. And we normally refer to that as the acid neutralization capacity, or ANC, acid neutralizing capacity. Every antacid should have a very good acid neutralizing capacity, because that is which determines how it is able to prevent excess acid from damaging. Not just that, having a good ANC is good, but having a good ANC with a good buffering capacity, I've introduced another term, a good buffering capacity is excellent. Why am I saying this? If an antacid gives a very good ANC value, but it is unable to sustain that pH for a long time, then the patient would have to consistently be taking the medicine, and that might cause a problem. However, if you have an antacid that shows good ANC and good buffering capacity, then it means that the pH that has been raised above the threshold of causing damage can be sustained for a very long time. So in the lab, we want to ensure that efficacy of an antacid is measured by knowing its acid neutralizing capacity coupled with the buffering capacity. These two are essential when it comes to identifying the efficacy of an antacid. Rahul, thank you.
Got it, sir. Very clear. So, uh, I mean, for any good antacid, acid neutralizing capacity, short form ANC, should be higher,
That's
and
right.
buffering capacity, that is BC, should be longer, which is measured in time.
Absolutely. That's right. That's
Got it.
perfect.
Very important and uh, is new knowledge indeed. So again, I mean, the flow of this discussion is that I will keep on moving from the researchers from both the probes to Dr. Bright to take the clinical viewpoint. And Dr. Bright, what do you think? What will be the clinical significance of these parameters like high or low ANC or high or low buffering capacity of antacids in clinical practice?
Thank you very much, Dr. Rao. So, as we've heard, Prof. Isaac has explained it so well, and he's made it very easy for me to explain from the clinical point of view. So, if you have this antacid, which has got a high ANC, then we know that it's going to be more efficacious because we're talking about it neutralizing a huge amount of acid because it has a high ANC. And then, apart from that, we know that we need symptom relief for a longer period of time and not to just have relief for a short period of time. You have to take more for you to get relief. So this antacid as well, if it has got a good buffering capacity, it's going to sustain the symptom relief such that you don't have to take this antacid every so often. You just have to take it. The frequency has to be reduced of taking this antacid. So clinically, we really want an antacid that has a good ANC and of course a good buffering capacity. And that will provide good symptom relief, which is also prolonged. And you don't want patients to be taking antacids every so often. I mean, it's inconveniencing. You want to take it and you stay for a longer period of time without having these symptoms. So that's the clinical significance. Thank you.
Right, sir. I mean, we can understand these are some very technical parameters. And being a clinician, we would like to know from you, Dr. Bright, that whether these parameters are taken into consideration by doctors, clinical practitioners, while prescribing or recommending antacids. What is your message for our doctor audience today?
Just to mention that, in most cases when people are prescribing these drugs, actually, they don't take such things into consideration. But honestly, that is supposed to be very, very important in our clinical practice. For example, you have somebody who is a very busy person, and you don't want them to be carrying an antacid everywhere they go. So you want something that has a good buffering capacity, such that when they are at home, they take the antacid, they go for work. The next time they are going to take is probably when they come back from work. So these are some of the things that we need to be considering as we prescribe some of these antacids to our patients. And then the other thing is that you have to look at the frequency of the reflux events, for example. If the frequency of reflux events is high, I mean, you want to give somebody an antacid that has a high buffering capacity so that you reduce the frequency of those reflux events in this patient. If maybe the reflux events aren't so much, you can probably use one without a very high buffering capacity because those symptoms don't seem to come every so often. I think that would be the importance of the buffering capacity and the acid neutralizing um, capacity.
Fantastic, doctor. I mean, you have bring it to our notice about this important factor that the antacids with the longer buffering capacity, how it can be a good choice for the cases where reflux is again an issue. Wonderful. And now I will go back to Professor Ayansu. Uh, Thank you so much, Prof, for listing out these important key parameters that decides the efficacy of any antacid. I would like to know from you, Professor Ayansu, if you have got chance of conducting any study to evaluate these all parameters for the antacids in your lab.
Oh, thank you very much, Dr. Raul. I think I can share a few of the stuff we've been doing in our lab. And if you would permit me, can I share some slides now so that our audience can have a very good understanding of what we've been doing?
Sure.
Thank you.
So, can you, Tejas, there are some slides that are going to get shared. Can you see the slides, Professor Ayansu?
Not yet. It's coming
Tejas?
though. Yeah, I have
Yeah.
it. Very good. Now, this study has already been published in a renowned journal, and we did work on evaluation of the acid neutralizing and buffering capacities of some selected antacids in Ghana. To start with, we had to work with about 9 different antacid liquid preparations. We labeled them L1 to L9. All were selected in Ghana. The study went through the use of ANC testing from the United States Pharmacopoeia, and the majority of the brands that we worked with contained dried aluminum hydroxide, magnesium hydroxide, and others with simethicone. In order to reduce all kinds of biases, we had to work with 3 batches of each of the 9 brands. Effectively, we had to start by measuring what we call the preliminary antacid test. This test basically ensures that the product passes as an antacid. Once the product passes as an antacid with the preliminary test, now we would move on to the acid neutralizing capacity test. And here we measured the ability of the antacid to neutralize stomach acid to find out to what extent the product is able to hold back the acid activity. We moved on further to work on the buffering capacity. And here we looked at how they wanted to know the ability for sustaining a desired gastric pH for a considerable amount of time. Now, these two, the ANC and the BC, as we measured, please can we go to the next slide, was very, very, very interesting. And the results we obtained were very, 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 very compelling. What we tried to do was that for each of these products, we looked at the ANC value and then we looked at the buffering capacity. You would see here that the buffering capacity we measured in minutes, and you would clearly see that all the antacids had very good ANC values. But moving down, you realize that only one of them was doing so well, both with the ANC and with the buffering capacity. And again, we've been talking about the constituents of these antacids and realize that we would have an equimolar content of dried aluminum hydroxide and magnesium hydroxide in most of them, and some also contain the simethicone. You realize that L9 contained dried aluminum hydroxide, magnesium hydroxide in equal quantities, and that was supported by the simethicone. You would also see that the next two, L9 was L8, and you can see that there was quite close, similarity in terms of capacity to bring about ANC and then the buffering capacity. And so from this, we were sure that for a product to do well, Obviously, the buffering capacity as well as the ANC are quintessential. And it was also good, taking a good look at the constituents and realize that the quantities that are there were doing so much good to the product and its efficacy. So this is what we've done. This has been published since July 2020, and our audience can go online and you can get much details from this work. Thank you very much, sir.
Thank you so much, Professor Ayansu, for sharing the results of this study, which is published already recently, I guess, right, in
That's
Scientific Africa.
yes.
Very insightful uh, findings, which really, I mean, it is clearly going to guide our audience for the selection of the antacids. Now, moving on to next point here. I would like to know from Professor Bola and from Dr. Bright also, because this is one of the most common question rather, which consumers as well as sometime the healthcare practitioners may have in mind, that how often do we have to take antacids, and which is the best time to take the antacids. Start with Professor Bola and then we'll I think move to Dr. Bright. Professor Bola, you are on mute. Would you please unmute yourself?
Uh, okay, I guess I'm
Yeah.
good.
Yeah.
When we talk of how often to take an antacid, uh, without prejudice to the feeling of the person, because that has to go first. You can't actually say that you should take it so time. Most antacids are liberal in terms of their administration, and that is why the content, the ANC, and the buffering capacity have to come into play. Because left to a patient, it will take it as often as it feels discomfort. But a good antacid should not drag the patient into taking it as often as possible. When, especially, we know that the side effects of some of these antacids arise from their, frequency of use. In other words, uh, we may not say this is the how often you should take it, but the how often you should take it should be on the quality of the antacid we are talking about. The quality we detect how often, if it has a high buffering capacity, that means the patient will not, suffer the pain frequently. That means it will be elongated. The time interval between administrations, will be wide. So in terms of how often, barring the people who have a sort of near dependence, because it's not a clinical dependence, it's just a psychological dependence. Barring people with psychological dependence, a good antacid, should be taken maybe 3 times, 4 times a day. But it's important. It is very, very important that antacids are taken, before food.
Right.
They are best taken on empty stomach, as we say. An empty stomach is a stomach that has not received food, in the last 30 to 1 hour. That means, and an empty stomach can also be a stomach that has received food after 2 or more than 2 hours. But it is clinically important that you take antacid on empty food so that it does not, flush, the food out. Again, the total aim is to neutralize the acidity. If you don't have a semblance of reordering or the gastric coming into near normality, then it has implication on the digestive juice. It has implication on the food that you want to digest. So that's my take.
Right, Prof. Yeah, I would like to know from Dr. Bright your views, sir, from clinical side.
Thank you very much, Dr. Rao. So, from the clinical point of view, I must mention that we look at how these drugs work, as Prof has mentioned. I'll take, for example, the proton pump inhibitors. So, for the proton pump inhibitors, you want the patient to take this drug like first thing in the morning, 30 minutes before they have the first meal. And the reason is simple. This is an empty stomach, and we know that these proton pump inhibitors, they inhibit the hydrogen pump. And for the hydrogen pump, the amount of these hydrogen pumps on the parietal cells is highest after prolonged fasting. Because of that, you want the proton pump inhibitors to irreversibly bind to these pumps when they are a lot, so that then you have maximal effect, such that if somebody is on once daily a proton pump inhibitor, you want them to take 30 minutes before they have their first meal in the morning, because it's going to have maximal effect. Now, going to the antacids. For the antacids, from the clinical point of view, we know that indigestion and heartburn would usually occur when somebody has a meal. So we would want these patients to have maximal effect at the time when they have the symptoms. So it's advisable that from the clinical point of view, one takes the antacid, say either with food or immediately after eating, because then it's going to have maximal effect. And we know that for gastrin release in the stomach, you have increased gastrin release in response to meals. And we know that with increased gastrin release, you're going to have hyperacidity with intake of meals. So for these that neutralize the acid, you probably want these patients to take them with food, and of course, or immediately after eating. And with some antacids, they actually tend to act for a longer period of time when they are taken with food. So from the clinical point of view, that would be my response. Thank you.
Right. So what I have taken from this discussion from both the sides is that it is gastrin which gets up gastrin level once food is consumed, and that is the time when there is a need of something to neutralize the acid which is going to get produced because of the high level of gastrin triggered by the food. Isn't it, Dr. Bright? Just to summarize.
Yes, it is.
Perfect. Okay. Now, to Professor Bola, this is little tricky question now here. Why some antacids are more effective than the others? What is your view on this?
Well, it depends mostly on the composition. Yes, the composition. Apart from the composition, because can you share the slide of our work? Maybe it will assist.
Right.
Yes.
So yeah. So our colleague Tejas is going
While
to, yeah.
while
Tejas,
waiting for
please
that,
share the slides.
that's the comparative efficacy and efficiency profile of commercially available antacids in the Nigerian market. It was published in 2020, by the West African Journal of Pharmacy, which is the official organ of the West African College of Postgraduate Pharmacy. Now, can we have the next slide? Okay, when we had about 10 different antacids from the Nigerian market, um, the what we did was to first see with the approval of community pharmacists that we consulted to see their book, to see the antacids that are, mostly, patronized. So from there, we selected about 10 so that we are sure that at any time they will be available, to the consuming populace. It's from there we selected all these, and we found out that the acid neutralizing capacity for most of them, because we are talking of efficacy and efficiency. You know, uh, Professor Ayesu described the efficiency as a buffering capacity. Whereas the efficacy is the ANC. And you see that that is the point at which you separate some of these antacids. You find out that a particular one, the ANCIG, had ANC of 27.52, leading the pack. Of course, the 1H also had 27.50, closely, closely coming behind. When we look at the composition of all this, that what could, be the cutting edge in the ones that are leading, we found out that some of them have combination of aluminum hydroxide, magnesium hydroxide, and simethicone. So we focus more on those to see how efficient. And in the efficiency, rating, this was also repeated. Now the efficiency rating has to do with the time, just like it was pointed out. The time, how you are able to hold on to that neutralized environment for how much. And this one has implication on how often you may have to take this. Because if the stomach returns to status quo so early, there'll be a need to take the antacid more. However, if you have the antacid holding for a longer period, then you don't have to take it as often, just as we discussed the other time. But in terms of why one is different from the other, apart from some of the things that may be common to all, a source of raw materials, the manufacturing procedure, and all those things, the composition, and in this context, we found the content of ANC as IG as like the ideal composition, giving us a cutting edge, on the other parts. Thank you.
Right, Prof. So, just to summarize this wonderful study which you have published recently, that there are few important compelling factors like composition, which are the antacids. They are going to be used in the product, and then how they are performing on these parameters like buffering capacity or ANC, that is acid neutralizing capacity, or how they are able to maintain pH level at different time points.
Yeah.
Wonderful. Now moving on to more clinical side. The next point, Dr. Bright, would like to know from your experience that broadly the place of antacids in acid peptic disorders management, which are the situation where antacids monotherapy can play a role in management, and which are the conditions where antacids can be given along with some other treatment options, maybe separately, but given together as a combined approach. Dr. Bright, you are mute. Would you please unmute?
Thank you very much. The role of antacids in management of antacid has actually evolved, and right now we know that they actually have a role to play. When we are managing, for example, gastroesophageal reflux disease, management is dependent on the severity of symptoms and, of course, the frequency of symptoms, whether the symptoms are intermittent or whether somebody has severe gastroesophageal reflux disease with erosions when you do endoscopy. I would take the side of the milder side with intermittent symptoms. That's where the antacids have got a very big role to play. Firstly, in managing these patients, you start with dietary and lifestyle modifications. With that, then you add the H2 antagonists. So at that level, you even give a low dose. You can, at this stage, give concomitant antacids to this in these patients with milder disease. So by milder disease, we mean that these are patients with intermittent symptoms and they have, say, less than one episode per week. In such a patient with less than one episode per week of the reflux symptoms, actually even monotherapy with antacids can work. If you have less than one episode of reflux event per week, monotherapy can work. But if you have more than that, the antacids can be used concomitantly with the H2 antagonists, and of course, together with dietary modifications and lifestyle modification. So these antacids have got a role to play, and it all depends on the frequency of symptoms. The more frequent the symptoms, the more you need to use them concomitantly with other medications. So that's the use from the clinical point of view.
Right, Dr. Bright, well taken. So since you have mentioned about H2RA, like tidins, all the tidins, there is one question. Now I'm trying to merge questions asked by audience in this discussion, right? So that it will go in flow. One of the question we have got from the audience that what is the current place of this H2RAs in APD's management, considering recent some warnings have been issued for some of the drug members under this class?
Sorry, I didn't quite get that question.
Regarding H2RA, histamine receptor 2 antagonists like cimetidine, ranitidine, and all the drugs listed out. One of the question we have got from the audience that what is the place of this class, H2RA class of drugs in APD management, considering some recent warnings have been issued for some of the drugs come under this particular class?
Thank you very much. I know that the professors from the with a pharmacological background, they would be able to give a better answer to that. But my understanding is that we got, of course, that news, and in our country, I think one batch was actually even withdrawn from the shelves because of certain information that came up. But the guidelines, even from the American Gastroenterology Association, they will tell you that the H2 receptor antagonists still have a role to play. And most importantly, it depends on the severity of symptoms, the frequency of symptoms, and the presence or absence of erosive esophagitis and Barrett's esophagus. If you have erosive esophagitis and Barrett's esophagus, they certainly have no role to play. That's when you have to go to the PPIs. But if you have non-erosive esophagitis and non-erosive reflux disease, and the symptoms are mild, and you have a reduced frequency of these episodes, they still have a role to play together with the antacids.
Got it, Dr. Bright. And sorry, I missed the point to which you mentioned that antacids and PPI can be, they can make a treatment strategy, right? In some conditions,
All
taken
right,
separately.
thank you. Yes. So I'll take, for example, peptic ulcer disease.
Yeah.
We know that acid secretion is mostly highest when you have gastrin release, when you've taken a meal. Of course, the antacids will not play much of a role when it comes to healing the ulcers, but in terms of symptom relief, they will still provide symptom relief and, of course, prevent, for example, entry of very acidic fluid into the duodenum. Okay, so they will still have a role to play, but not to heal the ulcers. The PPIs themselves would heal the ulcers, but in terms of symptom relief, they may have a role to play. And that's the reason why I must say that we don't give these antacids like regularly. We give them on demand. They're supposed to be taken on demand, and not where you say you're going to take the antacid for the next 5 days, 7 days. They're supposed to be taken on demand because they are there for symptom relief. They will not clear the H. pylori. They will not heal the ulcer, but they will provide the much needed symptom relief, and somebody you may have less impairment of daily activities. Thank you.
Fantastic. Thanks. Thank you, Dr. Bright. I will now quickly move to, since we are running late, Professor Bola, would you please briefly shed some light on antacids and drug interactions part, because it is very common precaution which is taken, right? And there are few questions from the audience from this area. Why antacids are responsible for drug-drug interactions, preferably on pharmacokinetic side. Would you please unmute yourself, Professor
Yes,
Bola?
I just did that. Now, when we talk of drug-drug interaction, particularly as it affects, the antacids, like we said earlier, that antacids are salts of heavy metals: aluminum, calcium, sodium, magnesium. All of them have, because of their composition, their propensity to either, form complexes with some of the other drugs that are administered. It's not only with drugs, it may be possible, also with food. Now, let's go to the basics. Let's look at tetracycline, for instance, the antibiotic tetracycline.
Yeah.
Now, when you take it with any antacid, there's a complexation reaction. What is formed becomes unabsorbable. And when it is not absorbed, there's no availability. That means everything will be washed down. That's, that's a typical explanation, for drug-drug interaction. Now, when you also, the same goes also because you have some of those functional groups that can attach to all of these heavy metals: aluminum, calcium, magnesium. They're all always available for attachment, for complexation. And when you have that complexation, you have a bulk molecule that's not absorbable.
Right.
So that is the explanation for the drug-drug interaction. Thank
Fine.
you.
So, considering these factors, Professor Bola, how much time interval you will recommend between antacid and any other drug?
Yes, my initial advice comes to play now. Antacids are short-acting. By their nature, they are a local, they have local activity. They are not absorbed. Therefore, their role is to just do local neutralization. Once they finish the neutralization, you can, take your drug. Now, exactly what we are saying is some of the very fantastic antacids, the initial effect lasts for at the most 1 hour. After after that, so what that means is you give a spacing. You give a spacing between the administration of your drug and the antacid. And because the drug that you want to use may have a very long half-life, you have to take the antacid first, let it do its work so that the issue of complexation and all those interactions may not arise. It just time heals everything, so you separate them by time administration. Pharmacokinetically, that is, uh, that's agreed, and that's the way it is. Thank
Right.
you.
Thanks, Professor Bola. Next point, and also we have got a question that which factor, Professor Bola, one should consider uh, in relation to effective management of some local side effects. They are associated with the antacids.
Well, by the composition of most antacids, well, you have the magnesium acting fast, the aluminum acting longer, the uh, aluminum, have the propensity to cause constipation, while the magnesium causes diarrhea. So a balance of this will neutralize some of these side effects. However, you have some other antacids for so many reasons, having some other composition or components. Uh, if something has licorice, for instance, if you have an antacid that has licorice, it is eventually metabolized into a compound called 11 beta dihydroxy, sorry, 11 beta dihydroxy, what's this? Okay, shortly, then the hydrogenase, the dihydroxysteroid,
Okay.
you know, dehydrogenase, which uh, will have problems of water retention, of problem with the, it also has, problem with this substance that is excreted by the kidney, by the suprarenal, the one that causes people not to sleep. We need it for, it just escaped my mind now. Now, I will remember shortly. Once you have licorice, once it's degraded, it forms some of these that have all these consequences. The consequences are on people with cardiovascular effect, two, on pregnant people, people are lactating, or breastfeeding. Therefore, you don't want them to take some of these components, licorice and the rest. Even though we have assumed that non-systemic antacids are not, absorbed, but with frequency, you see some of these substance is seeping into the systemic circulation. It's not intended, but you have seeping, into the systemic circulation, and they may cause some of these, side effects. What I was trying to remember was cortisol. Sorry, you know, when you have, cortisol, which is ordinarily responsible for our, daily activity or daytime activity, which have to
Right.
be suspended when we want to sleep. So you can see the effects, of all this. So again, we are saying that the composition matters a lot. The composition has bearing with the frequency. When the
Got it.
frequency is high, you have sipping and you have some of the side effects. Otherwise, an antacid is not an ideal antacid is not expected, to have some of these side effects. Thank you very much.
Thanks, thanks, Professor Bola, for such very well explained response. Now, I will move to Professor Ayansu. That there are some active ingredients we see in antacid products.
Sure.
Maybe we can call them adjuvants,
Mhm.
and they are not antacids, right? So, how is their role in this antacid products, Professor?
Thank you very much, Raul. And I would want to start from where it is easy to understand always, as I like it. If you take a look at what we've discussed, we've talked about those that are providing, increased basicity in terms of increasing the gastric pH. Now, what happens is that, as Dr. Bright has already suggested, you could have this regurgitation that brings the acid up. So, some of the products they would want to add some adjuvants. Let's mention a product like alginates or the alginic acids. They play a role like a float above the stomach content, preventing the reflux to occur. Good, but that product shouldn't just be the alginic acid, but it should come as in the case with calcium, okay, so that the floating capacity can be worked out well. Again, we have other adjuvants, like we've already mentioned, the simethicone. If you are not careful in trying to increase your pH of the gastric content, you might end up coming up with what we call rebound acidity. The problem you're trying to solve would mean that you are releasing carbon dioxide, which combines to effectively form carbonic acid. So it means you have also created another acid by giving your antacid. So producers would add a product like simethicone, which has capacity to defoam or to mop up the excess gases that would eventually lead to excess acidity. So we have products like the Sameticon, which plays that role effectively. And in doing so, it also helps to prevent flatulence. So if you took a careful look at the work that we did, you realize that most of the products did have Sameticon, aluminum hydroxide, and magnesium hydroxide. And these are the reasons why some of these adjuvants are added. They are not adding up to the increased basicity. However, they are there to prevent things that could happen because of your products that you have in your formulation. So I can just mention these two, that they are very good adjuvants. Other products will add so many things for special reasons, but these are two key ones that if you want to add, you should show an understanding without necessarily causing problems to the patient. Thank you, Dr. Raul.
Thanks, Pro. So, just to summarize it, that it is not going to add to, it is not going to play around the pH, but then it is certainly going to take care of some associated symptoms in these conditions.
Absolutely.
Right?
Absolutely.
Uh, so now, as I have mentioned that I'm just now embedding some of the questions already
Yeah.
asked by the audience, right? Because we don't have much time now. And the last question from the audience, I would like to go back to Dr. Bright. This is the last point or last question we are going to take up now in this panel discussion. For you, Dr. Bright, is there any age group which is more prone to gastritis than others? If is, why is that? You are mute, Dr. Bright.
Thank you very much, Dr. Rao. In terms of the age group, of course, we don't see much gastritis in the young ones. We see much gastritis in the older patients. And one of the reasons is that, the main cause of gastritis is mostly H. pylori infection, especially in our setup here in Africa, where, as we know, it's orophycal transmission. So we tend to see it much more in the older patients. And when you look at the other causes of gastritis, such as NSAIDs, we know that people that mostly use NSAIDs are the older patients. As you know, the older you grow, the more you develop these body pains, arthritis, osteoarthritis, and so forth. So you start using more of these uh, non-steroidal anti-inflammatory drugs, which then will predispose you to developing gastritis. So overall, you would expect to see gastritis in the older people more than in the younger ones. Thank you.
Fantastic. So, uh, thank you so much, panel members. I'm sure our audience will take so many take-home messages today from this panel of experts who have shared their experiences and views from very basics of antacid, very basics of disorder to its clinical applicability, because antacids are something which are commonly used and they are also available in most of the countries on over the counter basis. So I'm sure these learnings today you have got is certainly going to help in your practice. Once again, thank you so much, Dr. Bright, Professor Bola, and Professor Ayansu for taking out time from your busy schedule. And I would also like to pass on our thanks to our wonderful audience. Thank you so much for taking interest in our sessions, and we get your massive response through your feedbacks, suggestions. Keep on sending these feedbacks and suggestions, maybe topic suggestions. That will make our future webinars very interesting and very practice oriented. And lastly, but most importantly, would like to also pass on our thanks to professional bodies from these different countries who have accredited this panel discussion with CPD and CME points. Thank you so much. Have a nice day ahead.
Thank you very much.